in 2017, there was a lot of hype in regard to the radioembolization, and there was some kind of intrigue in regard to how can it replace even systemic therapy, and these trials were negative. But tell us a little bit more about radioembolization. What is it exactly?
So radioembolization is another type of arterial therapy following upon the successes of TACE or chemoembolization, which has been around since the early 2000s for liver cancer. Radioembolization is a technique wherein beads or little glass or resin particles are employed through the artery into the tumor vasculature with the intent to deliver a payload bearing radiation instead of chemotherapy, instead of the traditional chemo slurry or just the embolic material we used to deliver with embolization alone. And so radioembolization, usually with Y90 as the isotope at hand, has shown the ability to have prolonged responses, and has certainly been an important relatively new addition, I should say, in the intermediate or BCLC-B liver-dominant or liver-localized tumor burden setting when surgery or curative therapies like surgery, ablation, or transplant are not feasible. And so what the trials you're alluding to include the Survinib trial, which was conducted in Asia, comparing Survinib to sorafenib in a BCLC-B or early C, sort of a quasi-advanced, early advanced setting, and the SARA trial in a European population, similar degree of disease. And both of those studies highlight some of the challenges of comparing a device therapy to a systemic therapy. And I think one of the take-home points with the data is that neither of them showed superiority of the radioembolization over sorafenib as the control arm. And so sorafenib, they were both negative studies. And the challenge of interpreting these is that both of them suffered from a high proportion of dropout, meaning patients that with poor prognoses who progressed before they ever got to device. And that makes it very hard to interpret the data. But the take-home point is in the intention to treat population. They were negative studies, but again, hard to interpret their true benefit when you lose a lot of patients due to the wait time required to get a device on board.
By all means, if anything, the data, if I recall, the last effort of that nature, or one of the last efforts, was what was presented at ASCO last year, the Optimus study, and they are trying to understand really more about in the TACE setting. And if anything, if I recall, Dr. Pek Radosavlik, and forgive me if I forgot your name, or I know how to say it, but nonetheless, great work that you did at that time. And interestingly, he kind of concluded that at the end of the day, we are not really necessarily treating TACE by guidelines. And this really brings in a very important opportunity for discussion in regard to where to really set up the point between local therapy, to whom to apply it, and more importantly, what's the value for systemic therapy per se. And with this, actually, it will be nice to kind of like carry on the discussion in regard to systemic therapy. And I will start probably with Rich. Maybe you can give us, we're going to dissect them all, but give us just like a snapshot. Like we were talking about, our job was easy, sorafenib, period. And out of nothing, we have to memorize more names. So tell us more about it.
Well, we've had a lot of activity in the past 2 years, right? We've seen that for a decade, all we had was sorafenib. Right, and sorafenib has repeatedly shown its activity in liver cancer, its ability to extend survival in patients with Child-Pugh, well-compensated disease. For patients who have advanced disease, the Barcelona C, which is got patients with vascular invasion or extrahepatic spread, or patients who had intermediate disease that progressed on TACE or are refractory to TACE. And many drugs had tried to beat that. Right, and we had a gap in the frontline setting, something better than sorafenib or as an option, and then something after sorafenib. And at a very high level, we now have several drugs that are approved. And going in chronology, in early 2017, we had regorafenib approved as the first drug that showed an improvement in survival after progression on sorafenib. We then had data with lenvatinib, which showed that this drug was non-inferior to sorafenib in the frontline setting. We then had the accelerated approval of nivolumab in the second-line setting based on the single-arm CheckMate 040 study. And then we had results that you presented at GI ASCO 2018 of cabozantinib in second line after progression on sorafenib. And then Andy presented the results of the REACH-2 study showing ramucirumab improved survival in a high AFP population after progression on sorafenib. And then in November, again, based on a study Andy led, the single-arm phase 2 study of pembrolizumab in second line. And as we sit here today, of approvals, we have sorafenib and lenvatinib approved frontline, and second-line options approved include regorafenib, nivolumab, pembrolizumab, and cabozantinib.
Incredible. So as we just heard, literally we moved from one drug to 7. And the joke around is that, you know, as we, for example, if we're writing a review article, by the time we're kind of like finalizing it, maybe it's a good idea to go back because maybe some drugs really were already reported in between when we wrote it and when we are trying to publish it.